capsular tear, if you want to call it that, are very elastic. And it's this elasticity which gives great tear strength to the amorphous collagen. If you look at this with an EM study, you can see the rolled over edge there. We've done a study on paired cadaver eyes which showed that the edge of the capsulotomy created with capsulaser is twice as strong as that created with femto, and certainly also stronger than that you can achieve with manual capsulotomy. The laser is continuous. It is not pulsed like femto. It is scanned in a single circular pattern, and this creates the continuous curvilinear capsulotomy in under 0.3 of a second. We can see this now. The laser has been centered, and you'll see the significance of this in a moment, and there the laser is fired to create the capsulotomy. However, you can't use any trypan blue. It needs to be capsule blue, which is a 0.4% solution. Most of the commercial solutions that are available are 0.06. It is microfiltered, so there are no unwanted particles in it. Because it has a higher specific gravity of an aqueous, it means when you inject it into the eye, it will settle down onto the capsule. It has greater than 98% purity. And if you look at the ability to stain compared with Vision Blue or the generic trypan blues, you can see how much more efficient it is. We also found by chance that the coaxial Purkinje reflex and trypan capsular landmark are coincident. And you can see it here. There it is in the center, and you can see there's the Purkinje reflex beautifully in the center of it. Here we can see what happens if you use pupil centration. You get asymmetric coverage of the IOL optic. If you use the Purkinje reflex or the trypan capsular landmark, then you get 360-degree coverage, which is also beautifully centered and symmetrical on top of the IOL optic. And you can see the difference in terms of the nearness to the capsulotomy to the IOL optic. Also, if you look at the visual acuity, and this is as a result of a big study that we did, which was published last year in the Journal of Cataract and Refractive Surgery, that actually you get a better vision, unaided vision, if you center beautifully. So how does capsulaser work on complex eyes? We look at it in intumescent cataract, pseudoexfoliation, small pupils, capsular fibrosis, corneal changes, and also a subluxated lens. Here we can see the dye being injected. You then allow it to stain for 40 to 60 seconds, and then it needs to be very carefully washed out, because you only want the dye on the capsule. You don't want it anywhere else that is going to be anywhere near the laser. And now you backfill with a clear, optically clear OVD, and you can see that the central landmark will start to appear. Now you turn on the laser. There's an aiming beam that will focus, and then you center it and fire. And what you'll see is that the liquefied milky cortex is held back in the AC because the AC is pressurized by the high molecular weight OVD. So you've created your capsulotomy, and you can take it away, and as they say, the lens milk stays put. It doesn't fluff up in front of you. We recently completed a multi-center study of 93 intumescent cataracts, and there were no Argentine flag signs, and here we can see 6 of them. Now what's interesting here, you can see how much pressure there is interlenticularly, because the capsulotomy seems to expand and the cap seems to contract. You can also do small pupils. This is a case of from Jorge Alio. He's initially going to stretch the pupil. I wouldn't necessarily recommend this, but at least you can use the capsulotomy with laser here by reducing the size. This is one of our older cases. You could see how much slower the capsulotomy was there, but it was able to do it and reduce the size to 4.9 millimeters. Here we can see a pseudoexfoliation eye, which doesn't want to show. Anyway, you can do it with a small pupil as well. Oops, let's go. And this is an interesting one. This is with subcapsular fibrosis. And the picture that you can see up at the top there is actually of David Mordaunt, who invented this laser. He is the preeminent inventor of ophthalmic lasers in the world. He invented catalysts, he invented Pascal, he invented SLT, and he also invented capsulaser. Now see what happens here. We center on the central landmark and fire the laser. But when you start to peel this off, you'll see there are some fibrous strands. Now these are not going to interfere significantly in the removal of this cap. can either pull them away gently like this, or if you want to, you can use your chopper, if that seems more appropriate. But the great thing is you can see exactly where they are so that you can deal with them. And it might be that you might need scissors, but most of the capsulotomy will be cut here by the laser. And if not, as I say, you can remove it very easily and still end up with a very good capsulotomy. Now this is an interesting one. This is some corneal opacity. There's a scar in the cornea. So what's going to happen here? Well, because laser is light, it will not be fully transmitted. You can see how the scar is there. We've done the washout, we've done the stain. And then what will happen when we apply the laser is that there will be a good cut for most of it, but there will be an area where there will only be a partial cut. But it also means you can see exactly where it is. And because of the strength of the capsulotomy edge, it is perfectly possible just to peel this away and get a nice result. And there we are. We've got a beautifully round capsulotomy as you would want it to be. Now this is a difficult case. This is a sublux lensed. And what we're going to do here is to use a dispersive viscoelastic to provide a dam over the area of the zonular weakness. You can then put the dye into the eye and stain the capsule. You see it's not going backwards into the vitreous. You can now irrigate it away. You're left with your capsule stained the way you want it to be. Put some more OVD in. And then once you've got this done, capsule laser will affect the capsulotomy that you want. And now you can start to put in place your hooks and everything else that you would want to use to create a situation where you can do your removal of the lens. And now it's all safe. You can peel off the capsulotomy and you can see what this looks like at the end. So in summary, selective laser capsulotomy with capsule laser is a safe, predictable means of creating a strong, sized, circular and centered capsulotomy in more complex cases. In eyes with intumescent cataract, capsule laser provides the technology for minimizing unexpected capsular tear-out. The microfiltered 0.4% trypan blue solution provides excellent capsular staining with 60-second exposure to the capsule. And the trypan central landmark offers a means of accurate centration without the need for patient fixation. I'm involved with the ESCRS, as you heard from Amar just now. Our main meeting is in September this year, and I invite you all to attend, and thank you for your attention.
Thank you very much, Richard.